Hi there, this is Ben with HCO Thrive, and today we're going to talk about our methodology for our local area healthcare utilization projections, or LAHOP. More specifically, we're going to talk about our service line utilization projections, and that includes ER admissions and inpatient overnights, as well as our home health utilization. The first question we want to address is, why does it matter? From our perspective, there's a lot of reasons, but primarily it boils down to planning and or marketing purposes. Future utilization can help in terms of strategic planning. It can help identify future trends over a longer time horizon. In terms of workforce planning, for healthcare, supply always needs to meet demand. So if there's a gap, organization may be able to make future plans in terms of how many employees they'll need to hire over the next X amount of years. Can also help with location planning, identify areas for expansion. And finally, in terms of marketing, all of the aforementioned planning, as well as information on utilization based on demographic change, could help inform future marketing strategies. Currently, with some exceptions, most of the available utilization projections are done from a public health perspective. What this really means is that they tend to focus on primary care and nursing and more general areas that affect the broader population. And an example of this, and probably the best known example, is the Human Services Resources Administration, HRSA. And they do it at the state level by occupation and specialty. They also do supply. These are done on a semi-regular basis, usually every 4 to 5 years. And these are helpful, but they tend to lack detailed information. At the more local level, states tend to, at least maybe 12 to 15 states, maybe more, tend to provide you projections as well. The scope is a lot more narrow, though. This is usually in terms of RNs or primary care physicians. Again, information is limited, and these are even less regular as a whole. Finally, there are some commercial organizations that offer projections as well. For one, I know that the advisory board, I believe they used to, they may still. So this can be helpful, but again, this can be cost prohibitive, and they often do not include detailed methodology. So based on these factors, we decided to create our own, both to help for our internal purposes, adding auxiliary data to existing sources to get a better idea, and then, of course, for your purposes, in case they're helpful for any of those reasons we mentioned above. As for our approach, it's fairly similar to the HRSA with a couple of differences, but the similarities are we developed the model using the Medical Expenditure Panel Survey. This model is used to predict utilization, and the model is taken, and then utilization is predicted using other data sets with demographic and health variables, specifically for adults, BRFSS, and then for children, the ACS, American Community Survey data. After we have predicted utilization rates by geography, then these are multiplied with population projections, and we get the resulting utilization. Although there are a fair amount of similarities, there are also differences as well. Probably the main one is that it's provider-centric. So the idea is information that could be useful or relates to the provider itself. This makes sense given our name, Healthcare Organization Thrive, HCO Thrive. And this is in contrast to HRSA and others who look at it from a public health perspective. We also do regular updates. So they're updated every couple years, and this ensures that new data is incorporated into the model as soon as it is available. And as noted earlier, we've just focused on demand for the time being. That may change in the future, but we do not provide estimates of supply because that can be quite complicated. And finally, we won't go into too much details. We can later in a separate video if anyone's interested, but we use a model, again, predicted utilization via a model, whereas HRSA uses a statistical matching process for estimating in the geographic data. In this slide, you can see at the top the overall image of the process. Again, start with the MEPS dataset, create a model based on demographics and health conditions, use that model to predict in either the BRFSS, Behavioral Risk Factor Surveillance System, or the American Community Survey, ACS. From this, we get predicted utilization at the geographic level, so at the state level, And then that's combined with population projections. Those are controlled to a future outcome so that they don't differ from standard projections. And that's basically how the sausage is made. And we'll talk about each of the data sets in turn. So to start with, we'll talk about MEPS, Medical Expenditure Panel Survey. As you can see at the bottom, the figure outlines the panel design. Obviously, this is an old figure going back 10 years or so, but it remains pretty much the same. Different rounds, different times data is collected over a period of time. I imagine almost all healthcare researchers are familiar with MEPS because it's really quite a useful survey. Its primary advantage is that it has information from all sorts of payers. So you'll have information from people on Medicare, Medicaid, private, and so on. In addition, you'll get a lot of other information, utilization as an outcome, but also spending, a wide variety of demographic characteristics, chronic health conditions, perceived health status, and more. So all in all, very useful data set. One downside is it does not have specific geographic information other than what I believe is census region, which is a very broad category, and there's only 4 of them. Unlike MEPS, BRFSS does contain geographic information, at least at the state level. It also includes a variety of demographic and health conditions that are also included in MEPS. The one downside with BRFSS is that it only has adults, so those who are 18 and up, which is why a different data set was used for the children. And as an example, you can see the image at the bottom, which is one of the sections, disability, and the question is asking about if the individual has difficulty hearing. Again, this is also in the MEPS dataset. For those aged 0 to 17 years, we used the American Community Survey to model the utilization. And as noted, this is because BRFSS doesn't have those younger than 18. American Community Survey represents a 1% sample of the US population. The survey has quite a few variables, and it's really the reason that whenever the census comes out, there's not very many questions. It's really just about where you live and who's a resident, because the Census Bureau gets most of their information from the ACS on an annual basis. And it does contain fairly detailed geographic areas, public use microdata areas, or PUMA, and this is an area of 100,000 people or more. Sometimes this coincides with counties, but sometimes it doesn't. Sometimes they're larger, so you may have multiple counties within a PUMA, and then occasionally, I believe there might be instances where there's several PUMAs within a county as well. But luckily, it does contain many of the same demographic variables as does MEPS, so it is able to be used in that regard. County-level population projections were derived using an adaptation of an article by Hauer in 2019. This was published in the well-known journal Science as a sort of a side area for data. Very briefly, methodology included using a time series, ARIMA, and then use a combination of different cohort methods. Basically, the idea of this paper is that standard cohort component methods require birth, death, and migration data, which isn't really available at the county level, or at least not reliably, especially for small counties. So to address this, the author used a combination of cohort change ratios and then cohort change differences. Basically, this was done because in really small areas that have seen a high level of growth very recently, projections can then be astronomical, which doesn't really make sense. And then, of course, the converse is true for the cohort change differences. They often arrive at negative population values for areas where population is projected to decrease. Now that we've discussed the various data sources, I'd like to talk about the process a little bit more. This slide has an overview of harmonization and aggregation. Basically, what that means is for both MEPS and BRFSS, we took multiple years of data, the previous 5, and aggregated those together. In each case, it ended up being an N of about 90 to 100,000. For ACS, we just used 1 year, given that the size is so large, it's well over 1 million. A A very brief overview of service lines is when a healthcare system arranges its divisions around patient-related diagnostic groups. This is done generally to improve efficiency, has the potential for higher quality of patient care due to better coordination, and can aid profitability analysis and strategic planning. Examples would be a division for oncology, a division for cardiovascular, and so on. Within MEPS, for our purposes, service line utilization rates were determined by setting, so outpatient, office, etc., and then physician specialty. This was determined using the MEPS household component files, which give that extra detail on what type of doctor a survey respondent saw. And then lastly, the visit data was merged with these MEPS demographics and health status files, so you get the whole picture. Then you have one row for each patient, and then their total visits to the specialists. And finally, those visits were summed over a calendar year to get the outcome variables. As you can see in this table, these are the service lines that we modeled. Examples are cardiology, family practice, endocrinology, neurology, and then inpatient admissions, ER. As you might expect, the more specialized the outcome, the fewer cases there are. So for things like neurology, oncology, a number of them have relatively few, whereas some of the other ones you might expect, cardiology, general practice, have many, many cases. Another outcome we modeled was home health visit. And just like our service line utilization outcomes, these were also collected over a calendar year. We modeled 3 different types of home health visits, which of course were included in MEPS. Agency-based, this is your standard patient contracts or hires a home health agency to give service. Not agency professional caregiver, this is someone where it is paid, but the person is not affiliated with a home health agency. And then finally, informal visits, which, family, neighbors, etc. And then a total variable that's the summation of all of those I just mentioned. Model explanatory variables were chosen for a variety of different ways and reasons. First is research on the determinants of healthcare utilization. So which demographic factors predict healthcare? Usually people who are very, very young, like infants, pregnant mothers, and elderly. Those are just a few examples, as well as chronic health conditions, emphysema, high blood pressure, etc. These variables also had to be present across different data sets. And then finally, variables were selected based on their contribution to the model fit. And below in the table, you can see the demographic variables that were included. A few of them, like education level, I believe household income is included in the ACS, but I don't think it was a good predictor. So only a subset of these were included in the child model based on availability and or fit. Here you can see the health condition variables. These were only available in the adult model. So these were only used for the modeling with MEPS and then the BRFSS. And you can see smoking, whether or not the person smokes, stroke, emphysema, etc. And with the exception of the smoking variable, these are all binary, so 2 choices. Smoking had a large number of missing across both MEPS and BRFSS, so a category for missing was also included. And finally, we come to the disability or difficulty variables. Again, these were only used in the adult model, so difficulty seeing, difficulty walking, variables such as those. As noted before, utilization variables were operationalized as the sum of visits to the provider. One exception is total inpatient nights. As you can see on the bottom right, that's an example Poisson distribution. And you can see in this example, there's a lot of different events clustered around 3, 4-ish. And just to be clear, this is just an example. This isn't any of the distributions in our data sets. And then it tails off down towards the right. Now, when you deal with healthcare utilization variables, it's going to be even more skewed. So you're going to have a huge number of zeros, like a number of 1s, 2s, and then it'll really tail off with a few at higher levels, as you'd expect. What this leads to is something called over-dispersion, which means a typical Poisson regression is going to have some issues. It won't be quite as accurate. So instead, we used, on the whole, negative binomial regressions. It really depends on the model, depending on the fit and over-dispersion. And as you just saw, models were run in groups of 3 different variable groups, starting with demographics, health conditions, and then disability. For just about all models, those that included all three different groups of variables performed the best. And when I say perform the best, that's in terms of AIC, BIC, so common fit statistics, as well as residual analysis and dispersion statistics. Here we just have a summary slide for the model estimation, same diagram as before. The long and short of it is, though, two separate models were run, one for children, one for adults, on MEPS data set. These were run using count models, primarily negative binomial regressions. Coefficients were saved, and then depending whether it was those under 18 or those above 18, predictions were run with either BRFSS or ACS. And from that, we had our predicted utilization in terms of raw probabilities. And then the final step, which we'll talk about, was multiplying that with the population projections. In order to do that, the survey data, BRFSS or ACS, were grouped at the demographic and geographic levels, and then those means were taken across all the different health predictors and any other demographic predictors, and the weights for those means were from the survey weights. After this was complete, then the data set was joined by demographic characteristics, age, sex, race, as well as geography, and then the utilization rates were merged with the population projections by demographics and geography, and then rates were multiplied by population, rounded, and that results in the projected utilization estimates. So as you can see, accuracy and validity are a function of the stability of the current trends by the population projection accuracy and the utilization model accuracy. The first term really refers to what the surveys are capturing in terms of demographics and utilization, health conditions, etc. The second is with respect to how valid are those population projections. The original article did do some attempts at validation and found that it was fairly good fit and errors were within reasonable bounds. You can see the image on the bottom is from the article actually, and that's absolute percent error. And then finally, it also depends on the validity of the utilization model that we developed as well. And the long and short is basically that it assumes present trends continue into the future, which may not be feasible. Take the recent pandemic, for example, but after a year or two, things kind of leveled out, which is what we expect going forward. So that there may be incidents that affect utilization, but that over a longer range, over a longer time horizon, those will all even out. Of course, there's a number of limitations with the model. One of them I've mentioned a number of times, which is really that we're not capturing county level variation. So think of, say, recently Flint, Michigan, where the water quality may or may not be contributing to health issues. But then again, that's in a fairly large population county. So the consequence of that is what you expect in that smaller counties estimates will probably be less accurate. On the other hand, larger counties will be more accurate as the demographics tend to outweigh any local variation. Data dependency is really referring to the common expression garbage in, garbage out, so that any projections or estimates are really a function of the quality of the data. Luckily, the government puts in a lot of work to make sure that these surveys are representative and accurate. Research has tended to show that even for sensitive topics on the BRFSS, that respondents tend to be truthful and accurate. And again, population projections are going to be more accurate in the near term, next 10, 20, 30 years. Going further, going to be less accurate because we aren't sure about potential changes in immigration, birth rate, death rate, etc. All that aside, there's also a number of advantages as well. In particular, that MEPS has all the different payer sources, which is really good from a researcher perspective. The sampling is quite good too, in that it can reach underrepresented groups that are hard to get at. I also believe that the simplicity is an added benefit. This process is highly extensible, so if you're interested in only, say, Medicare beneficiaries, you could use the MedPAR data utilization from there. You'd probably get some extra information that we don't have. Alternatively, if you're a health system, You can use your own collection of payer mix and specific claims. You could also use the Optum database. And if you want, you could swap out the population projections as well. So every part of it can be easily switched out for something else, which makes it extensible and fairly easily to adapt. And as I've reiterated multiple times, we believe it's quite useful for planning purposes. One example is that many states require certificate of need before anyone starts a new healthcare business. Some states have very, very specific requirements, so you want to check with that, but this is another thing that these utilization projections could be helpful with. And of course, marketing, workforce planning, strategic planning, all that. There are a number of different modifications and or alterations we may undertake in the future. One is to try and separate skilled nursing facility projections. The real issue with this, and particularly using MEPS, is that there's no question on MEPS, which differentiates, say, an acute care hospital from a skilled nursing facility. Potential ways one might address this would be looking at ICD codes to see which ones are commonly used for skilled nursing facilities. This can be imperfect, though, or look at what percentage of all hospitalizations result in a stay at a skilled nursing facility. But either way, there are some challenges with that. Another is to continue to refine and or validate population projections. And finally, there's the possibility that we may begin to try and model supply, just like HRSA or a variation thereof, if that's helpful for anyone. And that's it for our healthcare utilization projection methodology. If you have any questions, please let us know. And thank you very much for watching.